The topic of this talk is role of CMR in assessing cardiomyopathies. No disclosure. So CMR has emerged as a powerful tool in the assessment of cardiomyopathies. It has several advantages. It has excellent spatial and temporal resolution, gold standard for quantification of cardiac volumes and function, and better tissue characterization, can detect focal scar and fatty infiltration as well, and there is no ionizing radiation. So one advantage of CMR is that it offers accurate and reproducible measurements of cardiac volumes and function, and can better demonstrate LV and RV regional wall motion abnormalities, and can also provide accurate measurements of the wall thickness and the exact pattern of hypertrophy as well. So we will discuss them one by one. First of all, discussing the hypertrophic cardiomyopathy. For hypertrophic cardiomyopathy, echocardiography is usually used for diagnosing hypertrophic cardiomyopathy, but focal hypertrophy can be challenging on echocardiography, especially the LV apex is susceptible to near field artifacts. And here is an example of a patient who has, apical hypertrophic cardiomyopathy, but here you can appreciate on echo, the apex is akinetic. But when we did the CMR, there was apical hypertrophic cardiomyopathy, but there was significant clinical evidence and significant ECG findings on this patient, and so we did the CMR. So LV apex is, as I told you, in cases of LV apex, even the echo would be, may miss the diagnosis or may give you the wrong diagnosis. So CMR is useful in these patients. CMR is also useful for assessing or risk stratifying the patient with hypertrophic cardiomyopathy, as well as for making the differential diagnosis of hypertrophic cardiomyopathy. These are the two cases in which you can appreciate that there is delayed enhancement and there is significant patchy hyperenhancement, which is signifying the high risk patient. Differential diagnosis of hypertrophic cardiomyopathy is mainly with the Fabry's disease. So Fabry's disease is a rare X-linked lysosomal storage disorder caused by mutations in the alpha-galactosidase A gene, and it is reported in approximately 1% of patients with left ventricular hypertrophy on echocardiography or a hypertrophic cardiomyopathy phenotype. Accumulation of glycosphingolipids inside the lysosomes in Fabry's disease significantly shortens the native T1 values. So while doing the T1 mapping in these patients, we can differentiate between the hypertrophic cardiomyopathy and Fabry's disease, because in Fabry's disease, the T1 values are significantly shortened, while in hypertrophic cardiomyopathy, it would be increased. So about 75% of cases would have also late gadolinium enhancement in the basal and mid-inferior lateral wall in the left ventricle in case of Fabry's disease. So pattern of delayed enhancement was also different, and T1 mapping was also different. The T1 values were also different. So on the basis of which you can make the diagnosis, differential diagnosis, because as I told, the 1% of patients with hypertrophic cardiomyopathy might be having, of a left ventricular hypertrophy, might be having something else other than hypertrophic cardiomyopathy. So these are the guidelines, and they recommend that when there is, you have suspected hypertrophic cardiomyopathy and echocardiography is inconclusive, then you can go for CMR. Similarly, for patients with LVH in whom there is suspicion of alternate diagnosis, you can go for CMR. And similarly, for patients with hypertrophic cardiomyopathy who are not otherwise identified at high risk or in whom a decision to proceed for ICD remains uncertain, then you can take the help of CMR. So this is dilated cardiomyopathy. In case of dilated cardiomyopathy, it is characterized by enlargement and systolic dysfunction. So CMR is gold standard for calculating the volumes as well as the ejection fractions of both the chambers, both the LV as well as the RV. And the CMR can also differentiate between the ischemic cardiomyopathy and the non-ischemic cardiomyopathy, because the pattern of hyperenhancement, जैसे कि डॉक्टर सज्जाद ने भी बताया, the pattern of hyperenhancement would be different. In case of ischemia or infarction, it would be from endocardium to epicardium, while in case of dilated cardiomyopathy, it would be either there will be no hyperenhancement or there may be mid-myocardial hyperenhancement. So these in 30% of cases with with dilated cardiomyopathy, you may have mid-wall hyperenhancement. This is a typical pattern of mid-wall or mid-myocardial hyperenhancement in a patient with dilated cardiomyopathy. So 30% of these patients have this kind of hyperenhancement. This I have already told you, and these patients are again high risk for arrhythmias and high risk for sudden death. So you not only diagnose the dilated cardiomyopathy, but you can also risk stratify the dilated cardiomyopathy for sudden death. So in dilated cardiomyopathy, absence of late gadolinium enhancement predicts LV reverse remodeling with treatment. This is another important thing. If you have done the CMR and if there is no delayed enhancement on CMR, but the diagnosis is dilated cardiomyopathy, then these patients may improve with medical treatment, even LV may improve with medical treatment. So the presence of mid-wall fibrosis on late gadolinium enhancement can improve patients for patient selection for device therapy. Or जिनको आपको delayed enhancement is present, you can select those patients for ICD implantation as well. Now come to the restrictive cardiomyopathy. Restrictive cardiomyopathy is characterized by restrictive cardiac physiology and normal LV volumes. And the main differentiation is from constrictive pericarditis, and which is usually a challenge, whether this is because one disease is curative and the other disease is not curative. So it's important to make the final diagnosis whether this is restrictive cardiomyopathy or whether this is constrictive pericarditis, and CMR is helpful in making the diagnosis. And again, the ventricular interdependence would be there in addition to thickening of the pericardium. So there are different types of restrictive cardiomyopathy. Let's discuss them one by one. One is the cardiac amyloidosis, and echo findings cannot confirm the diagnosis in isolation, but on CMR you can find biatrial enlargement in case of cardiac amyloidosis, possibility of atrial thrombi, there may be thickened ventricular walls, there may be thickened interatrial septum and valves, there may be mild pericardial effusion, there may be pleural effusion because of the heart failure, and there would be diffuse late gadolinium enhancement. So these are the images of a patient with cardiac amyloidosis, and here you can appreciate that there is biatrial enlargement, there are thrombi, and there is diffuse hyperenhancement. And in these cases, it is difficult to null the myocardium over a wide range of T1 inversion recovery time. Sayed et al. Performed late gadolinium enhancement CMR in 120 patients, referred to a tertiary care center with confirmed amyloidosis. In fact, they found that 97% of histologically confirmed cardiac amyloidosis had abnormal late gadolinium enhancement pattern. And another thing which is important in the diagnosis of cardiac amyloid on CMR is T1 mapping, which is useful method for the diagnosis of cardiac amyloidosis on CMR as well. And these are the different patterns of T1 mapping. And again, you can appreciate that in case of cardiac amyloid, the T1 values are increased. So in addition to typical pattern of hyperenhancement, there is marked increase in the T1 values, which is a distinguishing feature of cardiac amyloidosis. And in cases of severe renal failure, only you can do the native T1 value without giving the gadolinium, and you can make the diagnosis of cardiac amyloid. However, CMR has a sensitivity of 80% and a specificity of 92% for the diagnosis of cardiac amyloid, and it cannot distinguish between TTR type and the AL type. And technetium pyrophosphate scan is used for the diagnosis of TTR type. Then come to the endomyocardial fibrosis. Endomyocardial fibrosis is a type of restrictive cardiomyopathy of unknown etiology, usually found in tropical countries, but you can see in our country as well. It has been associated with a number of factors, including tropical climate, helminthic infections, eosinophilia, certain cardiotropic viruses, and ingestion of certain foods like cassava. Endomyocardial fibrosis is characterized by fibrosis of the endocardium involving the apex and inflow part of both or one ventricle. It may involve both the ventricles or may involve one ventricle. Imaging criteria include obliteration of at least one ventricular apex with fibrosis or thrombosis. So this is a classical patient with endomyocardial fibrosis, and here you can see on early GAD image there is thrombus, and on late GAD image there is typical pattern of hyperenhancement endomyocardial hyperenhancement indicative of endomyocardial fibrosis. Now come to the iron overload cardiomyopathy. Iron overload cardiomyopathy is a secondary form of cardiomyopathy resulting from the accumulation of iron in the myocardium. It may be genetically determined disorder of iron metabolism or may be secondary to multiple transfusions in patients with thalassemia. And CMR can reliably quantify myocardial iron load in patients with hemochromatosis and thalassemia through T2 mapping technique. And this is the T2 mapping technique. And here you can appreciate if the T2 star value is less than 10, then it means there is severe accumulation of the iron overload. Then come to the ARVC, or maybe you can name it, accordingly. It may involve the left ventricle as well. And there is not only, so the diagnosis again depends upon major criteria and minor criteria. Dr. Parveen has already talked about the, ARVC, so I'm not going to detail of that. So you can measure the RV or calculate the RV volumes and function on CMR, but you can also see the focal areas of aneurysm or dyskinesia on CMR. Similarly, you can pick up the fatty infiltration of the myocardium as well as the delayed enhancement not only of the RV but also of the LV as well. Left ventricular hypertrabeculation or non-compaction, nowadays ESC guidelines says that it is not in the cardiomyopathy and it may occur in a number of conditions, but hypertrabeculation you can pick up on CMR very well. Now come to the Takotsubo's cardiomyopathy, also known as stress-induced cardiomyopathy or apical ballooning or broken heart syndrome, often triggered by severe emotional or physical stress, and it is characterized by transient LV dysfunction, presenting symptoms like chest pain and shortness of breath, mimic acute MI, and here you can appreciate that there is wall motion abnormality, but when we do the angiography would be normal in these patients, and use of CMR, particularly in acute phase, assist in confirming the diagnosis, and identification of complications, that is presence of thrombus, would also be appreciable. The T2 value is, again, would be diagnostic because it would show the myocardial edema, but there will be no late gadolinium enhancement because there is no MI there. So this is typical patient with Takotsubo. There is myocardial edema because bright signals on T2 weighted images, but there is no delayed enhancement there. So these are the different types of cardiomyopathies. This is the local experience, and from our center, 294 patients were referred for CMR from 2011 to 2020 for evaluation of cardiomyopathy. Of these, 30% were ischemic cardiomyopathy, 26% were dilated cardiomyopathy, 25% were hypertrophic cardiomyopathy, 13% were restrictive cardiomyopathy, and 6% were ARVC. Among restrictive cardiomyopathy cases, cardiac amyloid was 29%, endomyocardial fibrosis 10%, cardiac sarcoidosis 13%, and suspected glycogen storage disease 3%, and rest of unknown etiology. So these are the different papers which we published from our center based on different types of cardiomyopathies. I'm not going into detail of these. So in conclusion, CMR is an important tool in the assessment of cardiomyopathies. It not only helps in the diagnosis, but also tells about the prognosis. Local data suggests that a poor prognosis in this region, probably due to delay in the diagnosis and less medical facilities. There is need to give more awareness about the utility of CMR in the workup of cardiomyopathies. Thank you.